Our dear colleague, Dr. Nausheen Ahmed. She is an associate professor of medicine at the University of Kansas Cancer Center at the Division of Hematological Malignancies and Cellular Therapeutics. She's also associate director and of the Cellular Therapeutics and a medical director of Cell Therapies Survivorship program. And she was a colleague here, did her bone marrow transplant fellowship training here at the Case Western Reserve University in Cleveland. So welcome, Nausheen. Thank you for agreeing to give the presentation. You can start.
Thank you very much to the organizing committee and to Dr. Anwar for inviting me to talk. So my topic today is aggressive B-cell non-Hodgkin's lymphoma. So it's a pretty vast topic, and we'll just be going through some management, specifically focusing on LBCL, as well as some, I would say, practical gems and clinical pearls that on the way, showcased by case illustrations. These are my disclosures. Just going back to the fact that lymphoma, aggressive non-Hodgkin's lymphoma, is really a heterogeneous disease and encompasses many different subtypes of lymphoma, which you can see over here. And we'll go through some of these in detail. I'll start with a case. We have a 54-year-old gentleman with hypertension, diabetes, and now came to your office with hip pain, night sweats, and a neck mass. And you get a scan, and that's what it shows. It shows some areas lighting up around the neck, some areas lighting up around the retroperitoneal area. CBC shows pancytopenia, and chemistry shows an abnormal LDH, and elevated LDH is 500. And because of the pancytopenia, you get a bone marrow biopsy. And the bone marrow biopsy is shown here. I mean, if I briefly describe it, it's basically sheets of cells, large cells. These are abnormal cells and shouldn't be there. That's a closer view down there of those cells. And then we go on to doing further investigation. The pathologist stains those cells. We do IHC on them, flow cytometry. IHC shows that these cells are CD20 positive. BCL, they express BCL2, BCL6, c-MYC positive, and a high Ki67 of 100%. We get FISH for gene rearrangement, and we see that the c-MYC is not rearranged. BCL2, however, is rearranged, and that's the only one of those three main things that we check. We check the MYC, BCL2, and BCL6 because you're already suspecting lymphoma. The flow cytometry sort of confirms, looks at the lymphoma cells in more detail, and we look at the expression of the surface antigens. It's CD19, CD20 expressing, similar to what we saw in the IHC. CD10 is positive. And this helps us to determine in some way cells of origin, which I call here CO, cells of origin, which is determined by flow. It can be determined by IHC. It can also be determined by molecular subtyping, which is the more up and coming way of describing these cells of origin or classifying these cells of origin. So it's broadly classified into germinal center or activated B cell type. And I would say the majority are germinal center. The activated B cell confers a more inferior prognosis, but it's only around 30% of the cases. And by IHC, it's mostly their CD10 positivity that is consistent with germinal center subtype. If it's CD10 negative, then you go and look at BCL6 and then MUM1, and there's this HANS criteria for classifying into a GCB or ABC subtype. The molecular signature is also important. We have been moving more towards a molecular-based subtype gene profiling, which will be the way of the future. And as you see here, the ABC subtypes on the bottom, the blue line shows that the prognosis is poorer with that subtype. So now that we have all that information, we have the morphology, we have IHC fish, we know what the gene rearrangements are. How do we decide what type of lymphoma this is? Like, how do we classify this? And I usually use this to give a broad idea of classification. When we're looking at aggressive non-Hodgkin's lymphoma, the first and foremost thing is morphology. What is the size of the cells? What's the look of the cells? For medium to large size cells, you're thinking more diffuse large B-cell lymphoma or high-grade B-cell lymphoma. When the cells get smaller, you're thinking more Burkitt's. So the next thing to look at is the c-MYC rearrangement. Is it germline? Is it rearranged? And that helps to further subclassify into DLBCL NOS, or is it high-grade B-cell lymphoma, and then and even further subclassifications, as you see there. Now, so say you have that lymphoma, the patient with lymphoma, and now you've subclassified it. I'll just go back a second. Oops, sorry. The cells are large, so you think it's fitting more with diffuse large B-cell lymphoma. The c-MYC is not rearranged, so you think maybe it's more towards diffuse large B-cell lymphoma NOS. You still need to further subclassify it. The next thing you have to know about the patient is what is the location of the DLBCL? Does it involve CNS? Does it involve the vitreous? Does it involve the testes? Because those are further subclassified into immune privileged site or immune deficiency associated lymphomas, or CNS lymphoma, which are treated differently. And also, if does a patient have HIV? Does a patient have an immune deficiency that could be contributing to the lymphoma? Did they just recently have a transplant, a solid organ transplant? Those are all taken into context. So I do have a question here, which is loading shortly. So that case that we discussed, we went over it in some detail. I'm going to ask you to scan the QR code and try to answer this question. What is the diagnosis? What do you think it is? Is it high-grade B-cell lymphoma, Burkitt's lymphoma, DLBCL NOS, or Hodgkin's lymphoma? So I'll give it a minute. All right, I'll give it just one more minute. Okay, so so far I see some responses. It's kind of 50-50 between high or the main choices here are either high-grade B-cell lymphoma or DLBCL NOS. The correct answer is actually DLBCL NOS. Okay, all right. And I'll tell you why. I mean, again, going back to that case, the cells were large cells, and so it fitted with more of diffuse large B-cell lymphoma subtype. And now we have to further subclassify it to see what type of lymphoma it is. The first thing we look at is the c-MYC, and the c-MYC was not rearranged. So if it was rearranged, then we would start looking towards, looking at, well, BCL2 and BCL6 and seeing, do we classify it as high grade, or do we, or if the cells were, say, smaller, a different size, then we would look at c-MYC and classify it as either Burkitt's or high grade. But here, with the morphology of the cells, and then the c-MYC was not rearranged, I would best classify it as diffuse large B-cell lymphoma NOS. Okay. And so let's talk a little bit about this, because this is the most common subtype, which is diffuse large B-cell lymphoma or just large B-cell lymphoma. It comprises of 30 to 40% of all NHLs worldwide. Annual global incidence is around 150,000 new cases per year. Most patients that are diagnosed, I would say the median age is around mid-60s. The marrow can be involved in around a third of the cases. And the markers are by flow or by IHC, you'd see the cells are positive for CD19 and 20 and 79A. These are pretty classic. These are just B cell antigens. And then, like we said, we have to subdivide those cells into cells of origin. So we look at CD10 and we look at BCL6 and MUM1, and that helps us classify whether these are germinal center or ABC phenotype. Now, just pearls for staging and evaluation. Every patient that comes to you with a suspected lymphoma, especially if it's DLBCL or you're thinking high-grade lymphoma, you want to get a PET scan. If there's ability to get a PET scan, you need accurate staging. A bone marrow biopsy would be ideal, especially if you're trying to look for any underlying low-grade lymphoma, or you want to fully document early-stage disease and make sure that there's no bone marrow involvement. LDH, we check paraproteins because paraproteins, like say with immunofixation, if it's positive, it could suggest underlying low-grade disease. Hepatitis, HIV status, EBV, HTLV, just infectious disease markers. So you want to see if there's anything that needs to be treated or anything that would impact your management, such as HIV status. Then you're thinking about your therapies, what you're going to give the patient, and some of them affect the heart. So you want to get an echo, you want to get tumor lysis labs. And then now, in terms of diagnosis and even management and following the patient, there's going to be an evolving role of circulating tumor DNA and clonoSEQ, and then, in certain cases, you want to get CSF analysis to see if there's CNS involvement, although not in all cases, but if your clinical suspicion is high. And then once you have your diagnosis and your staging established, you also want to have like a risk stratification. We have IPI scores. We use cell of origin, which we talked about in some detail. Molecular features, whether it's high grade or just DLBCL NOS, is consistent with more double hit, triple hit, which would lean more towards high grade. And then the clinical course itself. Once you start giving the patient chemo, how do they respond? That tells you a whole lot about how this disease biology is. So we'll talk a little bit about upfront limited stage disease, upfront advanced, and then relapse refractory. Just a quick note on IPI score, because we still use it in making some determinations on therapy. IPI score this was started even in the pre-Rituxan era and has been modified since. It looks at certain clinical features to determine what's the risk stratification. Is this patient a low risk or a high risk for relapse? We look at age, more than 60, performance status, abnormal LDH, more than one extranodal sites, and then advanced stage 3 or 4. And then based on the number of risk factors, they're assigned a score, and the higher the score, the higher the worse the prognosis. There's been many modifications of the IPI score, like the revised IPI score, the NCCN IPI score, and some other IPI scores, but this is just a general concept that you need to be aware of. So moving on to just limited stage, we're just going to focus on limited stage LBCL. This is a minority, I would say 30% of all DLBCL. It only includes stage 1 and stage 2. That means, just a single lymph node area or contiguous lymph node areas, non-bulky, that fit within a radiation field. The IPI score, which we talked about, has to be 0 to 1. And here the treatment's not really based on cell of origin. The treatments are mostly chemotherapy plus minus radiation. And the whole purpose of the chemotherapy and plus minus radiation, the whole focus of the therapy or the principles are that you want to give adequate treatment, but you don't want to overtreat. And at the same time, you want to be very mindful of toxicities. And that's how this field is evolving. It's evolving to use PET adapted strategies for early stage and trying to minimize toxicity. Just a few trials here. This is, back in 2019, this was the FLIER trial, which looked at just R-CHOP for limited stage, 4 cycles with then 2 cycles of Rituxan versus 6 of R-CHOP. And here they found that doing less R-CHOP was fine. It was equal to doing, was not inferior to 6 cycles of R-CHOP. So this helps reduce toxicity if you can do 4 and get equal results. Okay. Then we have this study published in 2017, the Lisa Golam's report, which looked at, which looked at the role of consolidative involved field radiation. So they did R-CHOP 4 to 6 cycles with followed by radiation versus just R-CHOP 4 to 6 cycles. And they found that there was no real difference. So R-CHOP was non-inferior to R-CHOP plus radiation, which means that in select cases, stage 1, 2 non-bulky, one may be able to omit radiation. And the best way to determine that would be to get a PET scan after around 4 cycles and then see if the patient's in CR, then you might be able to spare radiation. So how does this how do we, what's the practical value of this, or what do we do in practice? Here's just some, again, clinical pearls here. This is what we do. These are the things that we have to talk about when we get such a patient. First of all, it has to be stage 1, contiguous, or non-bulky stage 2. Everything else has to be treated as advanced. Options here are either just do R-CHOP 4 cycles and 2 of Rituxan, or R-CHOP 3 followed by radiation, especially if the PET is positive after the 3 rounds of R-CHOP, and this is for stage 1. Or if it's stage 2, you might want to do 4 rounds of R-CHOP, and then if the PET is still positive, do consolidate with radiation. And then the role of radiation kind of depends on the location. Is it fully resected or not? If the PET is negative, then the benefit at that point is uncertain. Another important thing is CNS prophylaxis. CNS prophylaxis is typically not, we typically don't need to do it. And we'll talk about this in a little more detail in the advanced stage LBCL. So moving on to advanced stage, we have the pre-Rituxan era, which shows that, there's all different chemotherapies. We use CHOP and other regimens, and they all were pretty much the same, and the prognosis remained poor. Rituxan helped actually double the prognosis. So it improved the PFS and it improved the OS significantly. It was a big advance that came in the field of lymphoma. And then there were many things done to see, can we improve on the R-CHOP? I mean, there was multiple strategies, substituting it, intensifying it, adding XYZ non-novel agent, and there's still studies ongoing. But so far, the only thing that really made headlines was the addition of polatuzumab, which we have incorporated in our practice over the last few years since it was approved. Polatuzumab vedotin is an antibody drug conjugate, and this is what it kind of this cartoon just shows us what it looks like. It has it has a CD79B humanized monoclonal antibody, which is a target which is found on the lymphoma cells, on the B cells. So it kind of finds the lymphoma cells using that, and then it releases a payload which is called MMAE, which is toxic to those cells. So it gets internalized, and then it releases that, and that can affect the microtubules and leads to cell lysis. The study that led to frontline approval of polatuzumab in RCHP is called the Polarix trial. It was a phase 3 trial. It looked at the regular R-CHOP versus 6 cycles of pola RCHP. So we took out the vincristine. The thought here is 2 things. Number 1, can it increase the efficacy? And number 2, can it decrease the toxicity? Because the main toxicity with R-CHOP was the neuropathy with vincristine. So we took out vincristine and added pola. And then this was followed by 2 additional cycles of just Rituxan monotherapy. Patients included in this trial were, patients age 18 to 80, good performance status 0 to 2, IPI 2 to 5, no prior indolent lymphoma, no CNS involvement. And we had the 5-year outcomes reported. PFS was improved. 64% in the POLA arm versus 59% in the RCHP arm. So there was a slight improvement in the PFS, which is more pronounced actually in the ABC subtype. So if you look at the ABC subtype and then, higher IPI. The overall survival, it was not significant, but I mean, people still like to use this regimen because there is that PFS advantage. And also because of toxicity profile, although it is almost similar, but probably like less neuropathy with polatuzumab based regimen. So that established POLA RCHP. Now, do we do CNS prophylaxis in all advanced cases or even, in the limited stage? The answer is that, well, we used to calculate, or we still do calculate a CNS IPI score. So similar to the IPI score, but this was more, had questions related to high risk for CNS involvement, such as kidney or adrenal involvement. And we saw that the risk for CNS involvement was higher if the scores were higher. But then in 2020, we had a report that showed that if you do IV methotrexate prophylaxis, or you do a higher intensity chemoimmunotherapy, that really wouldn't change the outcomes anyways in terms of PFS or OS. So it really didn't make a lot of sense to do CNS prophylaxis in everybody. A consolidated auto transplant did show that there was a benefit, but that would be, that's not widely practiced just for CNS prophylaxis. So we would generally, the general rule of thumb is that we don't need to do prophylaxis, but there are some important exceptions, such as testicular cancer, breast cancer, female reproductive organs, lymphoma of the female reproductive organs, or definitely if it's high grade B-cell lymphoma, Burkitt's, or receiving dose-adjusted RDPOC. And then, another thing is in frontline, up front, patient has been given the treatment, whatever you decided, R-CHOP, POLA RCHP. Now you get a PET scan, patient is in complete response. Do you need to do a transplant for CR1? And all the studies show that no, we don't have to. There's no additional benefit. You may, however, consider exceptions such as secondary CNS lymphoma and case-by-case basis on like double hit or triple hit lymphoma. This is just frontline in a elderly or frail. I won't go into too much detail, but just saying that if someone is frail or elderly, we can adjust the doses of the R-CHOP, make it mini R-CHOP, or substitute the doxorubicin within the R-CHOP, add gemcitabine to make it easier for patients who have heart involvement, or who are frail, or who have liver involvement. So just to recap, first line advanced DLBCL, excision biopsy should always be done, always test patients for double hit or high grade B-cell lymphoma biology. Always give rituximab with chemotherapy, because that has improved like double pretty much the PFS and OS. For advanced, 6 cycles of chemotherapy are adequate. There have been studies on more or less, but 6 cycles adequate. R-CHOP can be given as every 21 days versus 14 days, because studies have been done to look at that as well. POLA RCHP is a new frontline option. CNS prophylaxis is now out of favor for general cases, and transplant and CR1 is not routinely indicated. Now, all patients who are not in complete response by PET scan after completing R-CHOP, they need a biopsy, and you may want to they have to be very vigilant for primary refractory cases. So moving on to relapse refractory non-Hodgkin's lymphoma, I know that we're just going to do just a quick overview of this because there's so much in this field. There have been many novel therapies that have come out since 2017, I would say, with CAR T being the first. There are several different types of CAR T. I've tried to color code it as best as I could. If you look here, 2017, we have axicell, then tisacell, lysocell. So there's 3 CAR Ts. They were initially approved in 3rd line and then moved up to, lysocell and axicell are now also in 2nd line for patients that are chemo refractory, those that relapse early, those that may not be eligible for transplant. We also have other novel therapies that have come out. Polatuzumab, we talked about it in the frontline setting. That had come out in 2023, but before that, it did come out early in 2019 in the 3rd and later line setting. Then in 2020, we got tafasitamab, which we'll talk about as a CD19 directed monoclonal antibody, loncastuximab, which is a CD19 directed ADC antibody drug conjugate. And lastly, we do have in the last 2 years bispecific therapy, epcoritamab and glofitamab. This is just showing us that historically, LBCL has a dismal prognosis. If it relapsed and if the patient had the chemo, salvage chemotherapy, got transplant, and patient, relapsed even right then, they had a really poor prognosis and poor overall survival. But in today's day and age, with all those novel therapies that I showed you, things are a bit different. My approach in general to 2nd line LBCL, as well as high-grade B-cell lymphoma is this. I first want to see, is the patient chemo refractory and is the patient a transplant candidate? So when did the patient relapse? Was it within 12 months of their therapy, or was it the primary refractory? Did they never respond to that R-CHOP at all? And then transplant candidate, are they fit enough for a transplant? Do they have the support system for a transplant? Like all of that's taken into account. If they are truly chemo refractory, then we don't have to bother with more chemo. We go straight to CAR T at that point, axicell or lysocell. And if they're not chemo refractory, then they can get salvage chemotherapy. And it's really your choice. They're all pretty much similar, rice, R-GemOx, polabendarituxin. And then if they do well, if they respond, they go to a transplant. If they don't respond, then they still get CAR T in the 3rd line setting. Just a quick overview of some of these novel therapies. I won't be able to go into too much detail since this is like a very high level overview, but CAR T therapy is something that, I do pretty much a lot, so I can talk about it a little bit. So T cells, they're limited in how they can recognize the tumor. They need a 3rd party cell to recognize the tumor cell for them, and then knock on them to activate them to kill the tumor cells. So it's like a 3-way process. So what we do with these T cells is that we give them the ability to recognize the tumor by themselves with using the chimeric antigen receptors, which are synthetic receptors. They can recognize the cancer, the lymphoma, and then they can activate themselves. So they're pretty much having a more efficient process, which should translate to improved efficacy. And this cartoon B and C show us the CAR T, which has an antigen binding domain, which sticks out of the cell, and then a linker, and then activation domains in the bottom, and that activates the T cell. This is not like naturally present. These are synthetic, genetically modified T cells that have these receptors. And there's 3 types of, there's 3 different CAR Ts that we have in the lymphoma world: axicell, tisacell, and lysocell. The basic design is what I did show you, that part sticking outside, which recognizes CD19. And then co-stimulatory domains, which can differ a little bit between the 3 products. So there's slight differences in design in the 3 products, which I won't go into too much detail about. But this has sort of changed the paradigm, though, of the way we treat LBCL, relapse refractory disease. In the 2nd line, in aggressive non-Hodgkin's lymphoma, these are the trials that led to the approval. There were 2 trials, and there are 2 products that are approved: axicell and lysocell. And these were based on phase 3 trials, which showed that there was, almost a 3-4-fold benefit of using the CAR T compared to standard of care approach with chemotherapy. In the third line, aggressive non-Hodgkin lymphoma, these were trials that were published way back and have been approved. Axicell, Tisacell, and Lysocell have been approved since like 2017, since at least earlier than a few years, based on phase 2 trials that showed that they had a 30-40% PFS at 3 years, which was pretty huge when you compare to what the Scholar data showed. Like historical prognosis was terrible. Another class of drugs, other than CAR T, is a T-cell engagers. These are we call bispecifics. There's a bunch of them here. The ones that are relevant for us are the third and fourth one, epcoritamab and glofitamab. Both of these are used in non-Hodgkin's lymphoma. They target CD20. They bind to the CD20 on the cell, on the lymphoma cell. And they have another arm. So one arm binds to the lymphoma cell. The other arm binds to the white blood, the T cell, through CD3. And so what it does is that it tries to bring the T cell and the lymphoma cell close together so they can have a fight and they can kind of, activate the T cell and cause it to lyse or kill the lymphoma cell. We typically in clinic, one of the main things that we have to decide is which one to use because both are good, epcoritamab and glofitamab. Both have good response rates. And some of the things that I think about when I have to, when we decide about which one to give a patient is, the dosing. Epcoritamab is sub-Q versus glofit is IV. The ramp-up timing, epcoritamab step-up. So these are given in step-up doses because of their risk and side effect profile. Each of them are given small doses first with escalating doses, and then you get to the final full dose. The step-up is different. So with epcoritamab, it's the step-up is week 1 to 3. So it takes a 3-week ramp-up, and then you give the full doses, and then it's almost like every 2 weeks. There is a significant steroid use, and that has to be kept in mind for the right patient. I mean, for every patient, that might not be the right, the best way to go about it. With glofitamab, you have to give obinutuzumab 7 days prior, and then you give a ramp up over 2 weeks up to the full dose. And then after that, it is every 3-week dosing. So this is epcoritamab's every 2 weeks, and this is every 3-week dosing. And that might, be a decisive factor if the patient lives very far away and may not be able to come very frequently. Epcoritamab is not a fixed dosing, so it kind of goes on and on and on and on. Whereas glofitamab, after 12 cycles, you stop. Overall response rates, there's no direct comparison here. I just want to caution you. These are just based on their individual trials, but they're quite similar. And the populations served are pretty similar. And the side effects are also, we watch for cytokine release syndrome, neutropenia, fever, infection. So that's that. And then the other regimens that are used in relapsed refractory non-Hodgkin lymphoma is polatuzumab with bendamustine and Rituxan. And this was approved in 2019 based on a trial that showed that it was superior to just using bendamustine and Rituxan. It was a phase 1 trial. We did have patients with double and triple hit, which is important because sometimes there are some trials which did not have such patients. Overall response rates were 45% compared to 17%, which is pretty impressive for considering that patients back in 2017 had hardly any options. Then we have loncastuximab. So this is a CD19 ADC. So it's similar to what polatuzumab is, but it binds to CD19 on the lymphoma cell, and then it releases a payload of PBD, which lyses the tumor cell. This was approved based on the LOTUS-2 trial, a single-arm phase 2 trial. This included double hit, triple hit, primary refractory transformed lymphomas, and lonca is given every 3 weeks and overall responses were in the range of 48%, with complete responses 24%. I mean, which was, again, at that time, and even now, I mean, this is pretty impressive. Even as monotherapy, side effects, it's usually well tolerated. We watch for any liver function abnormalities, fluid retention, and all. And then the last one that I'll talk about is tafasitamab, which is a CD19 monoclonal antibody. So this is just a monoclonal antibody that binds to the CD19 on the lymphoma cell and then causes an antibody-dependent cellular phagocytosis, and it has a direct neoplastic effect. Preclinical studies have shown synergy with lenalidomide in that it activates the immune system NK cell ADCC to basically go after the lymphoma better. And so tafasitamab and lenalidomide in combination were approved in the relapsed refractory setting for diffuse large B-cell lymphoma based on the L-MIND study, which I show over here, where the response rates are 60%. The only thing to keep in mind is that exclusion, they excluded double and triple hit, and they excluded primary refractory, which are the really sick patients. And it was approved for patients that are not eligible for transplant. And then, real quick, I mean, there's always this question about auto transplant and allo transplant. Auto transplant does have a role. I didn't bring that up here. It has a role based on the PARMA data and other data. If someone has chemosensitive disease, like they may be relapsed 5 years out, from their first initial therapy, and then you give them salvage chemo, and then they respond to that, there's a role for consolidative auto transplant in that setting. Allogeneic, which is a donor transplant, which is more, I would say, a more involved transplant using a donor, because it not only involves chemotherapy plus minus radiation, but it also involves donor cells, which eventually become the donor immune system in the recipient, and can cause graft versus leukemia effect. That also has still a benefit, even despite all of these therapies. We don't do it very often, but it does have an improved survival benefit. And I won't go into all the nuances with allogeneic transplant, but just to give you an idea that this is out there too. So we have a few minutes. I'll just go over. We just covered DLBCL. Let's go over a few cases and a few other things like Burkitt's and all. All right, well, this case is a 23-year-old female, chest discomfort, progressive dyspnea, swelling of the face and neck for 3 weeks. And on exam, you see SCC syndrome. And the PET scan shows a mediastinal mass and no other involved areas. The biopsy shows large B cells, CD20 positive, CD79A positive, and CD30 weak. So you're already thinking about what this could be. This could be, because of the location in the mediastinum, you're already thinking, could it be primary mediastinal B-cell lymphoma, gray zone lymphoma, or classical Hodgkin's lymphoma? Now, Hodgkin's would be CD20 negative, but this patient had CD20 positive cells, and CD30 was weak. And so it could either be primary mediastinal or gray zone. And this really has to be determined by the pathologist, and sometimes even needs just expert opinion. But in our patient, eventually it turned out to be primary mediastinal B-cell lymphoma. And so in this patient, you decide to treat her with a dose-adjusted REPOC, which is the standard therapy for primary mediastinal B-cell lymphoma because they're more aggressive. And you do eventually get a complete response. Now, my question is this, and I would have you just scan the QR code. Would you consider a consolidative auto transplant in CR1? This is the first complete response. Okay. I'll just wait for some more responses and then. All right, well, the answer is actually Um, the actually answer is that you would consider it. And that is one of the exceptions to an auto transplant in CR1. I mean, this is one of the cases where you would. So, yep. Okay. All right. I'll go to the next one. Sorry, I'm trying to get the. Okay. Well, that was for primary mediastinal. Well, we'll jump on to Burkitt's lymphoma. Again, just time for a few pearls. There's no, this would be, again, Burkitt's is important to mention for aggressive non-Hodgkin lymphoma. We're just going to talk about it briefly. It is one of the most aggressive B-cell malignancies. Rapid doubling time, acute onset, progression of symptoms. It was originally described in African children who had jaw or facial masses. Presentation, bulky abdominal mass or jaw symptoms, B symptoms. Most of the time there's extranodal disease, bone marrow involvement, and many times you have CNS involvement. This is one of those cases where you have to give CNS prophylaxis with your treatment. The classification used to be based on endemic sporadic, but now it's more on EBV status, whether it's positive or negative. And this is your typical appearance of the biopsy, like a starry-skied appearance. And you will most commonly see an 8-14 translocation or IG mixed juxtaposition, which will kind of confirm your diagnosis. Treatment, I'll just give you the basic overview. I would say the majority of patients will be high-risk patients. A very, very small minority will be low-risk disease, which is just one extra abdominal mass, completely resected, normal LDH. All high-risk patients are treated with an intense regimen. It's called a McGrath regimen, or they can be some other variations of this regimen, which involve chemotherapy, cyclophosphamide, vincristine, doxorubicin, methotrexate, and IVAC, which is ifosfamide, cytarabine, etoposide, intrathecal methotrexate. If there is concern for toxicity, they can be dose-adjusted R-EPOC if they're older, like less fit. Hyper-CVAD can also be used, and CNS prophylaxis is an absolute must in these patients. So I haven't. With that, we'll go on to another lymphoma subtype. Let's look at this. Case 3, 70-year-old male with right testicular DLBCL. Now, testicular, if you remember, immune privileged site. So you consider orchiectomy and you start R-CHOP, okay? And so what other considerations would you have in the treatment here? And here again, you can use the QR code. You can use the QR code and just pick, would you do CNS prophylaxis in this patient with testicular cancer along with contralateral testicular radiation? Would you do CNS prophylaxis only, or would you just not do any CNS prophylaxis? Okay. Yep. The correct answer is CNS prophylaxis with contralateral testicular radiation. And the reference was given in the previous slide. Okay, very good. And here now I have my last question. This is just because I love CAR T so much. So I had to end with this. So the question is, and again, you can use the QR code here. Which aggressive non-Hodgkin lymphoma is CAR T approved in? And here you can check all that apply. And I'll give you a minute for it. Okay. Yep, I have a few responses in so far, and I'm pretty happy that most people did not choose Burkitt's primary CNS lymphoma. With CAR-T, we specifically, the label excludes primary CNS lymphoma at this point in time. And Burkitt's lymphoma is not really treated with CAR-T at this point in time. Okay, very good, very good. Okay, so the future, just leaving you with these thoughts. The future studies are look at the mechanisms of resistance, optimizing sequencing and combinations, personalized therapy, like how do we personalize it based on, say, circulating DNA, interim PET scan, and expanding the access of novel therapies in the frontline setting for patients with HIV, autoimmune diseases, or other nuances. Okay, well, with that, I want to thank all of you for being here and uh, hearing the whole lecture. And I want to thank, of course, my patients, their families, caregivers, friends, my mentors who have helped me develop my whole career and portfolio. All right, thank you.
Well, thank you, Dr. Nausheen. Did a great job. I'm trying to see if there's any questions in the chat or in the QA session. I don't see so far any questions.
Okay. Yeah, this was there's still, there's so many types of lymphoma and so many other nuances as with lymphoma management and that it's a very interesting and evolving field.
Yeah, it's the challenge is, there are so many lymphomas, so many therapies, so many settings, double hit, triple hit, newly diagnosed, relapse, first relapse, second relapse, CAR-T, bispecific. And so it's a huge topic. But I thank you for doing it. I saw that you covered a lot of those topics. And so if a patient comes, while we're waiting for, well, there is a question, looks like, can you explain how do you choose auto versus allogenic transplant?
Yes, so that's a really good question. So an auto transplant is mostly used as a consolidation. It's used more like I would say if you relapse one time, Um, so I'll just give you an example. You have a patient, they're treated with R-CHOP. I'm just going to use R-CHOP as an example. And well, they relapse 3 years later. They don't really meet the criteria for CAR-T or because they relapse late, so they're chemosensitive. So what you want to do is put them back into a remission and then kind of lock that response with an auto transplant. And an auto transplant involves just chemotherapy, high dose chemotherapy in order to really wipe out any clones of cells that might still be left back. So you decide to give them, I'm just giving an example, say rice for salvage, rice chemotherapy. They have a complete response. The disease is gone, nothing on PET. That's when you want to do an auto transplant for them. And this is going to be like second line, sometimes third line, but that's it. Now, if they relapse again after that, or if they relapse even after CAR-T or 2 or 3 therapies, and you just determine that this patient, just chemotherapy alone is not going to hold the fort, because that's all auto transplant is. It's just high dose chemotherapy with stem cell rescue. But if you decide you need more than that, you need graft versus leukemia effect or graft versus lymphoma effect. They've failed 2 or 3, 4 lines of therapy. That's when allogeneic transplant comes in the picture. These are much sicker patients. So you try to get them into a remission as best as possible with, whatever other salvages you have, and then you go for an allogeneic transplant.
Great. While we wait for the other sessions, so what will be your advice if somebody is practicing in Pakistan in a primary care setting and a patient comes in, has some B symptoms, have some palpable lymph nodes, how they can initiate the management for that patient?
try to get a buy. It's been a while since I've managed anything in Pakistan, so I don't know what I've heard is that, you know, PET scans are not as readily available. I mean, even over here in the US, it takes sometimes a few weeks to get to a PET scan. But I would start by just having a high index of suspicion, start by getting a biopsy, getting some scans, seeing what the extent of the disease is. A CT scan is typically used, seeing what the extent of the disease is, getting a biopsy. You really have to know, you have to cross the dots, cross the T's and dot the I's. Make sure you do this initial work really well, know exactly what you have to treat. And then with the pathologist's help, I mean, to try and classify, say if it's lymphoma, exactly what type of lymphoma, because that'll really guide your management after that.
Right. Yeah, no, I agree with that. I think if there is a patient being seen in a primary care setting, not in a big center, the first thing probably will be to try to get to this patient to a right center where they have expertise, where they can do scan, imaging, biopsy, and then initiate the treatment without further delays. There's a question under the QA session. Polar R-CHOP does not appear to be impressive in terms of PFS and R. So I think it's just your comment about Polar R-CHP.
So we have started using it, like generally across the board, just because, I mean, of that, you know, we don't want to use vincristine. Although I would say that there is, and we specifically use it. We try to get we didn't used to do this before. We didn't need to know what the cell of origin was, but now with polatuzumab, we know that it works better in the ABC subtype. So we try to get at least a cell of origin like classification. If it is an ABC subtype, I would try. Definitely, there's a higher benefit with using the Pola RCHP, or if there's a higher IPI. Sometimes it's hard though when you're establishing practices to make all those decisions, or so I would say across the board it's generally been accepted to use Polar RCHP. I don't know that that's a right answer in all situations, and I know that there's mixed feelings about it, but we have adapted it in general.
Great, thank you. I think this one question is about more of the e-certificate. We are not giving any CME for this live session. I can check with the UPNA Academy because this lecture is being recorded and it will be uploaded onto the UPNA Academy website. And I can inquire that if somebody goes there, logs in, and will there be a certificate or some sort of a proof that you attended and listened to the lecture recording, so we can work on that. There was a question under the webinar chat. What is your first choice of regimen, second line at the first relapse? Do you do bispecifics or CAR T cells?
Yeah, thank you, Vastia Ahmed, for that question. Yeah, if the patient relapses early, like within 12 months, my second line would be to go to CAR T. Bispecifics are approved more in the third line setting at this point in time, so not necessarily in the second line setting, although they're working their way up with clinical trials. So I would still use CAR T in the appropriate patient. That's chemo refractory patient that relapses early or that has not responded to therapy. Otherwise, if they relapse late, like I say, they relapse 2 years, 3 years out, I would still do the general chemotherapy approach, rice or GemOx, pola bendarituxin, try to get them to a response, and then see if they respond. I would do an auto transplant. And if they don't respond, then at that point, I would still think CAR T cell therapy. Because again, CAR T it does have in the chemo refractory setting an overall survival benefit. So I would definitely try to use that if it's the right patient. I think I see just one more question maybe we didn't address. This is by This is why do we need to rebiopsy if CR is not achieved in aggressive NHL? And I think this was probably based on the slide saying that after 6 cycles of R-CHOP, if someone has not achieved a complete response, then you want to rebiopsy. We do that again just to be thorough. So say if and it depends on the clinical scenario. I've seen patients where they have a complete response when we do an interim PET scan, and then the disease, then you start seeing traces of something coming up. You should rebiopsy and just make sure it's the same pathology. But if the patient just never responded to the therapy, like say after 2 or 3 cycles, you scan the patient, they're getting R-CHOP, and there's still significant disease, and then I would pretty much consider them primary refractory. It's just been our practice. It's just good practice to rebiopsy to confirm that there's no change in the histology. So wherever it's possible.
Rarely we may see change in the diagnosis. Many times, if this patient was managed at another center, you don't know what their expertise levels were. So when they come for a second opinion and they are primary refractory, you really want to review the tissues from the original biopsy and preferably do another biopsy to look for the exact diagnosis. I don't see any other question. It's the hour now. We are 10 a.m. here, local on the East Coast. So, Dr. Nausheen Ahmed, thank you again. Wonderful job. Lymphoma is a big topic, so we may have you come back and do another type of lymphoma, Burkitt's, Hodgkin's, T cells. There are a lot of flavors of the lymphoma, and there's tremendous need to educate physicians on this topic. So once again, thank you.
Thank you, Dr. Anwar, and thank you all of you. Thank you very much. Take care.
All right, goodbye.